good afternoon, depending upon where you are. I had the pleasure of looking at some of your introductions, and I can just share personally, each of y'all live in a place that if I'm ever so fortunate to travel, it would make me so happy. So again, my name is Ashley Kerr, and I'm an Associate Director of Nursing at MD Anderson in Houston, Texas. And it is also my pleasure to be here with one of my peers and an outstanding physician and educator and researcher, and someone who truly makes a difference every day in cancer history, Dr. Anuja Jhingran. And she is going to be joining me in this presentation. And so we're really thrilled to have her. I just would like to start off by saying that we all have something in common. Where I work, and I know where y'all work, we have a common goal through what we all do every day with our patient education, research, prevention, and just collectively to not only eliminate cancer where we're at, but globally and throughout the world. And RCC does that. And so again, thank you so much for taking time to spend with us today. And of course, when this presentation is done, if there's anything that we could do, feel free to get our contact information. And we'd love to be able to connect with you. Before I get forward, Dr. Jhingran, did you want to say hello and introduce yourself formally?
Yeah, hi, I'm Anuja Jhingran. I am a radiation oncologist and I only treat gynecological cancers. And we've done this a little bit differently, I think, than everybody else has, where I'm going to give an overview of how to treat cervix cancer, because we're going to concentrate on cervix cancer, because I think that's the primary gynecological cancers that you guys see. And then I'm going to hand it over to Ashley, and then we'll come back and talk together. But I'm so excited to be here, and I'm so excited that we're having a nursing course. So this is very exciting.
Thank you so much, Dr. Jhingran. I advanced the slide. I just want to make sure y'all are able to see this okay.
We are.
Okay, fantastic. We have quite a few wonderful goals for today. And the expectation after you leave is you'll be able to explain and have a good overview of cervical cancer. You'll leave with an overview of treatment for cervical cancer. We're going to discuss, and you'll be able to take away early side effects of radiation therapy. We're going to focus on also late and long-term side effects of radiation therapy. As Dr. Jhingran mentioned, this session really focuses on gynecological cancer. So we're going to spend a little time on vulvar and vaginal health promotion strategies, recommendations for sexual health, and then we're going to do a clinic visit workflow. We just want to point out that while we all bring wonderful education and experience to the table, our time today is not intended to, of course, replace the independent medical or professional judgment that any of y'all have as healthcare providers in the context of your own clinical experiences and circumstances to determine your patient care. Thank you. All righty, I'm going to pass this off to you, Dr. Jhingran.
Okay, but you're going to advance the slide since you're in
I
control.
am, yes.
Okay.
Thank you.
And we do have a couple of Zoom questions for you guys. So can we do Zoom polls? Jim, do we have that all set up, or is there any way we can do Zoom polls?
We should be able to. I'm going to try to add the questions because I didn't get them until a little bit later, but I'll try my best.
Okay, great. Sorry about that. Okay, so we're going to first talk about cervical cancer, because I think from what I see from everybody, this is probably the #1 cancer that you guys see. Sorry, I'm just going to change the language on mine because it says French, which I cannot speak. Okay. All right. Okay, cervical cancer, as we all know, is a global disease. There's over 500,000 cases worldwide. It is the 4th most common cause of death. In the United States, though, it's only about 12,000 new cervical invasive cancers in the US. Unfortunately, I think we're going to see a rise in cervical cancers back in the US because of our anti-vaccine movement that we're having. So I think we are going to see, unfortunately, a rise. It is a preventable disease by the HPV vaccine, which unfortunately is going to slow down, at least in the US, shortly. Anyway, but as you can see, but even by the map, it shows you where the most of the cervical cancers are. And you can see it's really in Africa, South America, and you can see India and parts of Eastern Europe as well. Okay, next slide, please. There's different, so I should put this in, so I'm going to go over the staging. So there is different stages of cervical cancer, and as you can see, it goes stage 1 to stage 4. These are FIGO staging, and staging is important. I think for radiation therapy, locally advanced cervical cancer is what we primarily treat. Early stage, which is 1 through stage 2A, is usually treated with surgery, then followed by radiation therapy. Anything from 2B all the way down to 4A is treated with radiation therapy, and then 4B is usually treated with chemotherapy. But as you can see, stage 1 is really just confined to the cervix. Stage 2 is going to go right outside the cervix, so whether it's the vagina or the tissue that's right outside the cervix, which we call the perimetrium. Okay, stage 3 though then goes a little bit further out, right? So stage 2 is just the vagina, which is right next to the cervix, or the perimetrium, which is right next to the cervix. Stage 3, we're going to go a little bit further out. So you're going to involve the entire vagina. So you can go down to the lower 1/3 of the vagina, or you go into the pelvic wall. So you're going towards the pelvic muscles, or you're involving the ureters, which causes the dysfunction of your kidneys. 4B then goes into your bladder and rectum, and then 4B is metastatic disease. Next.
And Dr.
Yes,
Jhingran, the
yes.
next 2 slides were added. I got some feedback. They just a little bit more of an overview of treatment modality, but it ties right into your next slide after that. Thank you.
Okay, perfect. No worries. All right. So yes, what we're going to talk about, and this is important, which I didn't do, so I'm glad that they put this in. So cervix cancer is treated with 2 treatments, right? One is radiation from the outside, which is external beam radiation. Okay. And one is brachytherapy, which is radiation from the inside, where you actually put the radiation inside the cervix. So for the nurses, I'm going to do my historical overview. Cervix cancer was the first cancer that was ever cured by radiation. So Marie Curie, when she found radium, she actually put it in a cervix of a patient with cervical cancer and cured it. And that was how radiation started. So just letting you guys know that cervix cancer was the first cancer that really was treated with radiation therapy, especially radiation inside. But cervix cancer is treated with 2 treatments, and it's really important. You have treatment from the outside and you have treatment from the inside. Outside is called external beam radiation, and there's multiple ways of giving it. One is called 3D conformal, which I have pictures of. And then the other, which is the more advanced type of external beam, is called either IMRT or VMAT. IMRT is intensity modulated radiation therapy, so it changes the intensity of the radiation beam while the treatment is delivered. And VMAT is a type of IMRT that employs arcs during the treatment. So basically and I'm going to show you a picture of this, right? Basically what IMRT and VMAT do is it treats the areas we want to treat and gives less dose to the areas that we don't want to treat, like bowel and bladder. Next slide. Okay. So internal. So this is the brachytherapy that we talked about, right? So cervix cancer, external beam first to shrink the tumor, and then we put radiation inside the cervix, which is called brachytherapy. There really is 2 different types, which is low dose rate or pulse dose rate. And this is where the patient stays inpatient, has a system in, and has a radiation throughout the 2 to 3 days while they're inpatient. This is actually going away, and actually most of the world does not have either LDR or PDR. The most common way of doing brachytherapy now in most of the world is high dose rate. This is an outpatient procedure. It's actually, so to be honest, it's not really 4 to 5 treatments. I think for most of you guys in Africa, it's either 2 to 3 treatments because of the number of patients you have. In the United States, it's more common, and Europe, it's more common to give either 4 or 5 treatments. They are given several days apart. You do it twice a week, but you have to have some time between. So what you do is you basically put the instruments in, you plan, you treat, you take the instruments out, and the patients go home. So the advantage is it is totally outpatient, and patients just go home. They don't have to stay in bed, lying flat on their back and having to stay still for 2 to 3 days. Again, please ask questions, and Jim is on and he can monitor the questions. And Jim, to be honest, please interrupt me. I tend to talk fast if people don't, because I'm talking to myself. So please, if there's questions, and Ashley, stop anytime that you think the nurses need a little bit more than what I'm saying. Radiation therapy. is the mainstay treatment for locally advanced cervix cancer. I'm just going to tell you that, you guys. This is the one cancer we cure with radiation, and you have to know this, right? But it has to be done correctly. So that means you have to treat all the disease that you know in the microscopic extension. You have to get the correct dose. So this is a little bit higher. You have to get about 85 to 90 gray to point A, and we can talk more about that. You have to do brachytherapy, right? Whether it's low dose rate or high dose rate, you have to do it. The other thing, which I'm going to show you a slide of, it has to be done within 56 days. And that's really important. So you have to do all of it, the external beam plus the brachytherapy within 56 days. So let's go to the next slide. So like I said, the standard treatment is external beam, 45 gray. So the external beam is 5 weeks. And what it does is it treats the cervix, and it treats the nodes around the cervix that are involved, that could be involved with microscopic disease. Now, again, in America, 45 gray, or in Europe, 45 gray is the most common fractionation. I do know in Africa, because of how many patients you have and how advanced, that there's a lot of times you will do 3 weeks of treatments, which is called hypofractionation, and that's okay as well. And we are actually, since COVID, we are actually investigating how to shorten the treatment time, especially since patients live so far away. And if you're there getting 5 weeks of treatment, they have to stay there for 5 weeks, right? So by shortening the treatment time, there's less time they have to stay in the place where they're getting the treatment. But also, because of the number of patients, shortening the treatment time, you can get more patients on the machine. Again, most cervix cancers are treated with radiation plus cisplatinum, and that is done weekly during the treatments. It's usually given Monday or Tuesday, and you should at least get 5 or 6 courses. This is really important for nurses to know. The typical is 5 or 6 courses of cisplatinum, and that is very important. Okay, very important. And then brachytherapy, like we talked about. Next. So this is a typical field of, and this is a 3D conformal field, which again, in Africa is, and like I said, there's a lot of participants pretty much all over the world. This is probably the most common still being used. And it's just a standard field that, you can see here's the nodes, here's the uterus and cervix. You can see the uterus. Oh, you can't see mine because Ashley's doing it. So I'm sorry. So the red is the uterus cervix. The purple is the nodes. And then you can see the bladder is in yellow and the rectum is in green. And what the 3D conformal, as you can see, treats everything in the field. So a 3D conformal field will treat everything that we need to treat, but it also treats everything that may not need full dose. We don't need to always treat all the bladder, all the rectum. So these patients, when we were treating this, which is still the most common, do have more side effects because we're treating so much of the bladder and the rectum. Next.
And
Yes.
Dr. Jhingran, for those of us who are younger, and I think we training era without a lot of exposure to 2D radiotherapy, could you touch a little bit on that as well in terms of that utilization?
Yes, so 3D conformal is 4 fields where you treat front, back, and the laterals, and 2D is up from the front and the back, APPA. And so you're treating everything in the field is just front and back, where the 3D conformal, you do try to shape a little bit off the bowel, and you can shape a little bit off the rectum. So 3D means that you're doing a CT scan or you're doing an X-ray and you're shaping the beams around the areas you want to treat, but you're still treating everything.
Thank you so much. And one of the quick questions from the chat, thank you. It asks, do all patients receive the same dose? Where does it depend?
No, so standard dose is 45 gray for microscopic disease. Good question. If they have positive nodes that you know of, the nodes go to a higher dose. And if you're doing hyperfractionation, it's usually 250 times 15. So they usually get about, what is it, 215? What is 250 times 15? I can't count today.
3750, according to quick calculation.
Right. So that's 3750. But 45 gray is for microscopic disease. Gross disease needs about 60 to 65. So if you have positive nodes, we will take the nodes to a little bit higher dose. But this is just microscopic disease. We're not going to use brachytherapy. So what I tell my patients is external beam, you get 50% of the dose. And with brachytherapy, you get 50% of the dose. So the brachytherapy will give you a little bit more dose to just the cervix and the uterus.
Awesome.
Next.
Thank you.
Keep asking, please. Can the dose be reduced at, what is the question?
And
Can the
those be reduced, presumably maybe in the
Yeah.
reassessed. Yeah.
Yeah, not usually. There's a set dose you have to get to. You have to get to 45 for microscopic disease, unfortunately. All right, next slide. That's a good question, though. Okay, so IMRT or VMAT, which is what we talked about, right? So you can see on the right side is a 3D conformal, and you can see where all that brown, that's your bowel, is getting full dose, right? And then on your left is your IMRT field, and as you can see, the isodose lines are curving in and avoiding some of the bowel. So what IMRT does is it reduces the dose to the areas we don't want to treat, like the bowel, the bladder, or rectum, and gives the dose 45 grade to the nodes, but gives less dose. It shapes it. That's the word. It shapes it to the areas we want to treat. And we have randomized studies that show IMRT or VMAT does reduce both GI and GU toxicity. Jim, do you have a better way of explaining VMAT or IMRT that I didn't say?
Nope, that's perfect.
Okay. All right. But you can see the picture, right? So on the right, you can see where the bowel in the middle is getting full dose, where on the left, the bowel is shaped, right? It's getting less dose. So that patient's going to have less toxicity. And we have studies that show that they do have less toxicity, which Ashley is going to talk to you about. Next slide. For IMRT, things that you may hear from your physicians, right? GTV is gross tumor volume, CTV is clinical target volume, and PTV is planning target volume. So this is what your clinicians are drawing when they are planning their IMRT. They're drawing out what they want to treat, and they're drawing out what they don't want to treat. And these are the new terms that came out, and you may just hear this, right? So GTV, it's the gross. So if you have a positive node, so like on this slide, there's a node. See that in orange? That would be your gross tumor volume. CTV is microscopic disease, and PTV is what margin we put on for movement during the treatment. Does VMAT do the, what does this say? Does VMAT do the beach or the, VMAT does external beam. VMAT is external beam, not brachytherapy. Correct. Okay, VMAT's a type of external beam. Next. So this just shows you just examples. So 2D is the top two fields, you can see that's 2D, it was front and back. It was just straight fields that were treating everything. Then we came to 3D conformal, where we did shape it a little bit, where we try to get off a little bit of the bowel, and we treat it from the front, the back, and the sides, so we could take some bowel out anteriorly and take some rectum out posteriorly. And then we got to IMRT. So you can see where this is, the fourth one is IMRT, where it's treating the uterus and cervix, and the high doses are the orange, and the low doses are the green. So you can see where it's sparing a lot. So here, the third slide, you can see that's 3D conformal. So all the orange, everything that's in the orange is getting full dose. But then you go to IMRT, which is that fourth one, where the green, you can see where the bowel is being spared, the bladder may be spared. So all the green is lower dose. And then the last one is where you can actually come back and you see where the red is the gross nodes. So the nodes are getting a higher dose, while the uterus and cervix is getting a little bit lower dose. So with IMRT VMAT, you can actually give higher doses to certain areas while giving different doses to other areas. I hope that makes sense. Right, front and back.
Great.
So the top two are 2D, where it's just front and back. So everything is getting the full dose. This is a good slide if somebody just stared at it. Next one. And this just shows you an example, right? This is an MRI, and you can see on the right is a huge cervix tumor. And again, I can't show it. So Ashley, I don't know if you can show, can you show that big mass that's in the cervix? So go back. You can use your arrows. Can you use your arrows? Because I can't, and I don't have it annotate on mine. I don't know why.
Let's see here.
Use your, can you use,
Oh.
nope, no, okay, go
Sorry,
back.
it's super
That's-
sensitive. Sorry.
Okay, so
Let's
yeah,
see.
so that big mass, you can see that big gray mass on the cervix. So that was pre-treatment. And then on the left is 4 weeks into treatment, and that big mass is gone. So you can see where that mass is gone. So this is just with external beam alone. So this is only 50% of the dose. So now we're going to do brachytherapy with it. So radiation, like I said, really works for cervix cancer. Just a big example of it. Next.
One moment. Thank you. My computer's extra sensitive today. There we go.
Okay, so that's fine. And this,
Exactly.
yeah, and this just shows you that time is important. Any day after 56 days, you do lose 1% of local control. So it's really important that we do not interrupt treatments and we keep the patients on treatment, which again, why we're talking about side effects and how to control side effects, which is what Ashley's going to talk about, because you don't want to have any patient take a break. Next slide. And this is the brachytherapy, right? And this one is old-fashioned low dose, right? So you could actually see it. So I just wanted to show it to you so you can see it. So the rod that you see in the middle, that goes into the uterus, and the two ovoid-like things are in the vaginal fornix. Okay, so the rod actually goes into the uterus, and the ovoids are in the fornices. And then in the old days, this is 2D planning, where we would take an AP field and a lateral field, and we would actually do points to determine the dose. But yes, so the tandem is the rod that goes in the uterus, and the ovoids are right outside in the fornices. Next. So just again, like we said with external beam, we've gone from 2D to VMAT. With brachytherapy, we've gone T-base to MRI base. So there's just all these slides just really show you. So we started with film base, which I think again, in a lot of countries, we're still doing film base, and that's okay. The problem with film base is you can't see the uterus or the cervix. You really can't see where the rectum and the bladder are. You're just guessing it by points. With CT, you can see the normal anatomy. So you can see the uterus cervix, you can see the bladder, you can see the rectum, you can see the sigmoid. So then we can figure out real doses to the organs at risk. And with MRI, you can actually even still see the tumor as well. Now, CT is probably the most common. In my institution, we do CTs with every brachytherapy. We do MRI with the first brachytherapy, and then we do CTs. In Europe, they do MRI with all their brachytherapies. But again, film is still good too. I started off with film. Problem was you just couldn't see the anatomy. But this is as external beam, like I said, we went to 2D to VMAT. With brachytherapy, we've gone from film base to MRI base, just so that we can see true anatomy. Next. Oh, wait, so let's stop. We'll go back. Go back, Ashley, sorry. So you can see the rod. So the rod is in the uterus. So you can see where the rod is in the uterus, right? And then those ovoids are going to be right outside in the vagina, which you can't see as clearly. But you can see where the rod is directly into the uterus, and it stays there. And then we put radiation sources right through that tandem. Next. And then the regimens, the brachytherapy regimens in the US and Europe, most common is either 7 gray in 4 fractions or 5 to 6 gray in 5 fractions. In Africa and other low, and I'm mentioning Africa just because I know a lot about Africa. I've been to Africa, but in a lot of other countries that are in this place, 8 gray times 3 is, and on this conference, 8 gray times 3 is probably the most common that is being used. 9 gray times 2 can be used. It isn't as common. It is a high dose and can have a little bit longer toxicity, more toxicity, but most common is 8 gray times 3 in low middle income countries, where the 7 gray or the times 4 or the 5 to 6 gray times 5 is more common in Europe and US. Next. And like I said, we cure cancers. And this is even pre-using chemotherapy. So this is even before chemotherapy. Now we do chemotherapy, so these numbers are even better. But you can see, even before the use of cisplatin, we were curing over 80% of patients with stage 2 and over 60% with stage 3. So radiation really does work. Next. So standard follow-up for patients is, for the first 2 years, we see them every 3 to 4 months. We do a physical exam, as well as a pelvic exam, pap smears once a year for patients with cervix cancers. Chest x-rays are no longer required, so you can take that off. In the US, we do a PET scan at 3 to 6 months post-treatment. If the patient's doing well, then we don't repeat it unless there's symptoms. So the first 2 years, you see them every 3 to 4 months. 2 to 5 years, you see them every 6 months. And then after 5 years, they're cured or considered cured, and then you see them on a regular basis. Next. So Ashley's going to start talking here, but these are the most common side effects when you do chemoradiation, okay? Diarrhea, cystitis, fatigue, and skin reaction. Chemo-related is nausea, vomiting, and I'm going to be honest, as a radiation oncologist, because we see them on a weekly basis, we're dealing with a lot of the chemotherapy-related toxicity. So nausea, vomiting is always usually related with chemotherapy, unless you're treating extended field. Then you could have nausea, vomiting from the radiation, heartburn, hematological toxicity, and combined is appetite, weight loss, and other infections. But I think this is my last, Ashley, then you take over. Is that correct? Oh, no, we have a Zoom question, right?
Yeah, we've got a Zoom questions. It looks
Okay.
like we have also a question. Oh, it just disappeared.
Oh, I got it. Keep going.
You got it? Okay, great.
Yeah, the question asks how many brachytherapy sessions cervical cancer patients receive and what kind of interval do they receive?
Right. So it's either 3 to 5 is the most common. If you're doing 3, I think that you do it once a week, or you could do it twice a week. If you're doing 4 or 5, you can do it twice a week. Like we do 5, so we do Monday, Friday, Monday, Friday, Monday. But as long as you have a couple of days in between, you can do that. But if you're doing 8 or 8 times 3, usually once a week is enough. Good question. Next slide.
Thank you. So Dr. Ling, if we're not able to make this be a Zoom poll, we've got the question here as well.
Yes, apologize. I wasn't able to get it
No
added
problem at
last
all.
minute.
Yeah,
Okay.
so
Yeah, so why don't we do this? Okay, so the question is, what is the standard treatment for locally advanced cervical cancer? Is it external beam radiation therapy alone? Is it brachytherapy alone? Is it external beam therapy and brachytherapy? Or is it concurrent concurrent chemotherapy, external beam, and brachy? Okay, so yeah, I see that. Good, guys. You
Yeah,
guys are
feel free
all
to put it in the
listening.
Yeah,
chat.
awesome.
Thank you.
Thanks,
That's
everyone.
great. All right.
Yes.
Okay, so we can go to the next slide, which says, yes, you're right. It is D. Very good. Okay, I'm glad you guys are all listening. Thank you.
Thank
Yeah,
you so
thanks,
much,
everyone.
Dr. Jhingran. I'm not sure, Dr. Ling, was there another question? Okay,
Yeah,
we've got one. A
there's
few
one quick
questions are coming up.
one. Yeah, Dr. Jhingran question, is brachytherapy useful for all stages in terms of cervical cancer treatment, or is just some of them?
No. It's brachytherapy, if you can do it, is really the most important thing. But like for stage 4A, if you have a fistula, you may not be able to do brachytherapy, but if it can be done, it should be done.
Awesome. Thank you.
Thank you so much, Dr.
Actually,
Jhingran. Yes, we are now going to switch over and spend the rest of our time together really talking about side effect management. And as Dr. Jhingran pointed out in that last question, we as radiation oncology nurses, in particular in the gynecological population, we have the opportunity to not just treat patients getting radiation, but they're also getting concurrent chemotherapy. So throughout this, I'm going to ask y'all to also think about what the premise of how do we want to assess our patients that are oncology patients, right? So it isn't just about the diarrhea, the cystitis, the dehydration, nausea, and vomiting that could be related to radiation therapy, but we also have to look for other symptoms. I'm not going to spend a lot of time on that today because I appreciate that you've had other teaching sessions about that. But remember, we want to think about what's happening with their counts, right? Or could they be neutropenia? Could they have sepsis? Depending upon where they're at in their chemo, their platelets could be affected, right? Their red blood cells. So many things. And that's why is radiation oncology nurses, we're the best, right? Because we look at the patient holistically from that standpoint. So let's go ahead. As I mentioned, some common short-term side effects that we see early on are fatigue, diarrhea, cystitis, dehydration, nausea, and vomiting. It also could be related to chemotherapy, as Dr. Jhingran pointed out, usually it is. pelvic pain, rectal, and skin irritation. And you should start to expect the side effects within approximately 3 weeks of treatment. But as you probably have experienced with your patients, some can start earlier in the treatment, depending upon how high the radiation field is. As Dr. Jhingran pointed out, sometimes we treat in the para-aortic nodes, and that can cause symptoms sooner than 3 weeks. And primary cause will be nausea and vomiting from radiation treatment. And fatigue, as we talked about, standard of oncology care, we want to think about our blood counts being low. So I'm going to pause, and I'd like y'all to put in the in the chat, what do we think the cause of fatigue is in our patients that we are treating? If you want to just put your thoughts in there. Cell death. Okay, yeah. So when they're getting concurrent chemotherapy, as you point out, chemotherapy is systemic, right? And so it does affect all of our cells in our bone marrow. Yes, many of these theories exist, you're right. But one of the things that we do anticipate is the patient's blood counts get low, and the impact of our blood counts getting low is anemia, and patients will have a fatigue because as we lose those red blood cells, it carries oxygen, right? And so you'll experience fatigue from that. They could also experience fatigue because there may be a change in their diet. There's a change in their lifestyle. So many things that we need to think about that aren't necessarily related to their radiation therapy there. So diarrhea is most common, and we're going to spend a little bit of time on that. So there's a slide that will focus on that. But we want to think about the type of diet we're going to encourage our patients to have. And as I mentioned, we'll spend a little more time on that. And then cystitis. So if you think about where we're treating, cystitis, the bladder is going to be irritated by the radiation, right? Causing urgency, frequency, and sometimes blood in the urine. So there's going to be a slide on that. And we usually depending upon where you live and what's available, sometimes there are over-the-counter medications we recommend to our patients, as well as we could also be prescribed antibiotics or other things. And then dehydration. If you want to put in the chat, tell me what are some things that y'all use where you're at to help with dehydration. We're going to have a slide about that, but I'm just interested to see your perspectives on this while I'm talking. And then nausea and vomiting, as Dr. Jhingran pointed out, depending upon where we're treating, primary source of that has to do with the chemotherapy. And we're going to spend a little bit of time talking about that. Okay, and I'll be pausing in a few minutes. I see some questions coming up, but I'll pause in between these slides, and either myself or Dr. Jhingran are happy to go through that. Early side effects of radiation therapy and management. Again, we want to think about experiencing fatigue within the first or second week starting treatment. And in particular, if there's concurrent chemotherapy, we know the counts also start to drop. We want to encourage our patients getting adequate rest. We don't want them, it's also important at the same time that they do have activities they can support. But again, we want to make sure they get adequate periods of rest. Can they nap during the day? That may help in particular to keep on a sleep cycle. And as we've talked about, our patients are going to need lab work because their counts will drop. They will drop, and then we anticipate them going back up closer towards the 3-week period. And if they don't go back up, then we might need to intervene with a blood transfusion or platelet transfusion. And then, as we mentioned, adequate sleep. Okay, so now we're going to break it on down and focus on some of the key early side effects. I see some questions.
Yeah.
Do you think, Dr. Ling, should we pause or
Yeah,
just let me know?
actually, yeah, I wanted to bring up one of them, I believe, from Saju from the chat. And thanks everyone for the great questions in the chat. I think two are relevant here. Saju asks, how is neutropenia related to external beam radiation? And we have another really relevant question right now from the chat saying, at what hemoglobin level would you recommend a transfusion?
I will be happy to defer the first question to Dr. Jhingran, and then I'm happy to take the second question.
So the hemoglobin is a big issue, right? I think, again, in the low middle income countries, and actually most of the world, they are still transfusing up to 10. Unfortunately, in the US, we are no longer allowed to transfuse unless they're symptomatic if they're 8 or higher, right? I do think we're seeing a lot more issues with that. I think there's still a thought that you should at least try to have 10.
Thank you. And I was just to add to that, Dr. Jhingran, or 7 or 8, but then We also have to look at our patient's symptoms. Our labs are just one component of it. So their hemoglobin may be 9, but if they come to you saying they have extreme fatigue, if we notice there's a concern with their oxygen level, right, if we're looking at their pulse ox or other things. So we also want to look at symptom management. I think that there was another question about when do we transfuse specific to a radiation therapy treatment? Did I understand that question correctly? Or maybe I misunderstood it.
I didn't catch that one, but I will look back and I'll bring it up actually if it comes up.
Okay, thank you. Very good questions. And we will get these questions, and I am happy to forward any other type of patient education that would be helpful. When I looked at the syllabus for all the classes, I made some presumptions as it relates to foundational oncology and chemotherapy, but I'm happy to send forth information as it relates to neutropenia, what we look for when we transfuse. Again, when we talk about platelets, going a little bit off topic, not only are you wanting to look at the platelet counts, but you need to look at what this patient's symptoms are having, right? Are they having bruising? Are they noticing that they're having nosebleeds? Did they come in and say that they just had a minor cut and it took them a long time to stop the bleeding? So many things that we need to consider there. But getting back to diarrhea. So diarrhea is the most common side effect because if you think about concurrent therapy and where we're treating. So nutrition, if you have the opportunity to do this in your area, it's always nice to bring in your dietitian. But as nurses, as we know, we have a foundation in teaching. So lots of really great resources out there for us to reference, and I'm more than happy to send you some specifically. But we want to think about our diet changes. So we want to avoid greasy and spicy foods, right? Because if we think about where we're treating, we don't want to irritate the GI tract and further. And then high fiber foods. Traditionally, we all want fiber in our diet, right? Because that promotes motility and stooling, and we want to have regular bowels. But in our patients, as we know, they already have irritation to that area. So we don't want there to be a lot of stooling throughout the day. So start your low fiber diet. Of course, talk to your nurse or your nutritionist or physician about that if you need a referral. Then even though we don't want to overhydrate, we definitely want our patients to stay hydrated. 8 glasses of some type of fluid a day. It could be water, depending upon if they're having a lot of loose stools. If you're noticed that they're dehydrated, you may think about an electrolyte replacement. In caffeine-free and non-carbonated drinks. Can anyone put in the chat why we'd like to avoid caffeine-free and non-carbonated drinks? So while y'all are putting your answers in there, caffeine, if you've ever drinking a lot of caffeine, that's actually a natural diuretic, right? And so if our goal is to have our patients stay hydrated, that's why we encourage caffeine-free. And then carbonated drinks, again, if you've ever had a carbonated water or something, what usually happens? You feel full, right? And so we already have patients that may have that feeling and sensation and just irritation to that area, so non-carbonated drinks. Then we want to focus on our diet. So again, if they're having diarrhea, it's the BRAT diet. So bananas, rice, bread, pasta, proteins. So that is something that we want to encourage our patients when they're in this acute stage with diarrhea. And then remember, not only is this about radiation, but for our oncology patients in particular, when their white blood cell counts are low, like we're talking neutropenic phase, we want to make sure all vegetables are cooked thoroughly, meat products, even fresh fruit, right, that's washed and clean, because what we don't want to do is have that be a source of infection for our patients. So our medication treatments, and this is going to be relative to what is available where you're at in your clinic, but here we usually give Imodium or loperamide. And so we encourage our patients to take 1 Imodium over the counter after each loose stool, but follow the directions on the box. We don't want to exceed 8 tablets in a 24-hour period because then we don't want to have the opposite effect of lack of motility. And then Lamodal, again, if the patient continues to have diarrhea, they can alternate. As I know y'all experience in nursing and when we educate our patients, they usually have quite a few tools in their box, as they say. So if, let's say, one anti-nausea medication isn't working, you can encourage them to try another, and they can alternate these medications. And we also need to focus on what's working for the patient in front of us. You may find that a patient says Imodium works really well for them, and the other patient says it does not. So that's, again, something else we want to consider for our patients. Okay, so we have another poll question. So I'm going to go ahead and read it out. And then if you could go ahead and put your answer in the chat. What is the best way to treat diarrhea? Low fiber diet, vegetables cooked and killed, as well as thinking meat products as well, anti-diarrhea pills, or all of the above?
And we're getting a lot of answers already in the chat.
We are all getting gold stars, A plus. If we were back in nursing school taking our exams, we'd all be really happy right now because we did really well. Yes, so the answer is all of the above. So think low fiber diet, vegetables, meat products, fruits, make sure they're clean, cook thoroughly, and any type of medication. Okay, fantastic job, everyone. All right, moving on to cystitis. Common symptoms with cystitis will be urinary frequency, pain or burning with urination, blood in the urine, and dark or cloudy urine. So we want to, again, that's how we explain, if we think about if our patient comes to us and they have these concerns, you may need to do a little more assessment before you make a definitive diagnosis, but usually that's related to cystitis, in particular with our gynecology patients, right? And so there's a few things that we're going to do. We're going to place an order for a urinalysis and a culture. And again, we want to make sure they do not have any type of urinary infection or something else that's happening. So you may have over the counter, we have a product here called AZO. You may have something similar where you live, and there may be prescriptions from your advanced practice provider, your physician. But here we go. We want to stay hydrated. We want to flush out their system. So we've already encouraged them to stay hydrated, but plenty of water or other fluids. If your patients have access to cranberry juice, that has a dual purpose. Again, we want to help flush out that bacteria. And then we want to think good hygiene. We want to remind our patients the importance of that. Wiping in particular with females, right? Wiping from front to back. That's important because if we wipe from back to front, then we are at risk, our patients are at the risk of introducing any type of fecal material, bacteria, and things of that nature. And then we want to ensure that they empty their bladder before and after intercourse. Again, by doing so, we're going to help hopefully inhibit any type of bacteria and have a good source of infection prevention there. All righty, moving along. So we talked a little bit about dehydration on some other slides, but some other methods to consider. How do we get our patients interested in drinking and also eating, which we'll talk about more in a little bit, if they don't feel like it? So whatever it is they can tolerate. So 8 to 10 cups ideally throughout the day. Encourage them to carry water bottles when they're at your facility. Maybe you can offer them cups of water that they can refill. We can also be creative here. If they have a frozen treat that they like, some patients just enjoy sucking on ice chips. They can add any type of, flavoring to their water. So the goal is to find out what they enjoy so they can be successful at staying hydrated. Again, we talked about, in this instance, fresh fruit and vegetables, as we know, they do carry water. So you just need to ensure there's no clinical indication to prevent them from eating fresh fruits and vegetables. And if your patient is extremely hydrated, and you'll note this on labs and other signs, so that you can look at their skin. I don't know if you can see this right now, if you pull up on their skin and it has a slow recoil, you could see things in their face and so on and so forth. So based upon your visual assessment as well, you might recommend to your provider that they get IV fluid replacement and potentially electrolyte replacement, and the patient's labs can help guide you in that. Okay, so nausea and vomiting, again, in particular with our gynecology patients receiving radiation, they're also receiving concurrent chemotherapy. So can be common. So before we talk a little bit more about this, go ahead and put in the chat some things that you do to encourage your patients to control their nausea and vomiting, but also be able to eat and drink.
And actually, while folks are putting things into the chat, a quick question with regards to diarrhea. Salamer asked, do corticosteroids such as dexamethasone have a role in managing diarrhea in your experience?
So that's a really great question. That is not normally our first or even second line of defense. If in particular, though, however, in that area, we do know that the radiation does cause inflammation, so it can help. But I will also defer to Dr. Jhingran to see if she has a standard practice question on, or standard practice answer on that.
I'm sorry, so what was the question?
Oh,
She was talking about the use of steroids as it relates to management of diarrhea, and
No, no,
yes, it's
no, no.
yeah.
I
Yep.
use
Thank
steroids for
you.
the management of nausea, but I will not use steroids for the management of diarrhea. No, 100% not.
Yeah, thank you. Just to highlight that, on the previous slide, we were saying that this is what we recommend for using for diarrhea, but that's a really good question. When we think about steroids, we know the concept of it is a reduction, if you will, depending upon what's happening in the body, right, from an inflammatory state. But in this instance, it doesn't have a direct effect as it relates to diarrhea. Okay, so thank you. I see some of what you're recommending in your chat. So again, when our patients have, oh, I like that, staying hydrated,
mhm.
mints, that's really good, in particular with nausea and vomiting. And I like the fact that you're thinking more holistic care, which we'll talk about a little bit, because we do have medication or pharmacologic interventions, but there are a lot of holistic interventions. You mentioned mints, aromatherapy works well with our patients. So that's something to consider. But in general, we want to make sure as we can, we're able to keep our patients' appetite up because, of course, if they can eat and drink, that means that they get energy. It will help them to not lose weight. Our patients, our oncology patients during treatment, they do lose weight usually, but we want as nurses to prevent that. So things that we should be considering here, encourage our patients to eat small, frequent meals. The reason for that is usually our patients can tolerate a small amount. If they can't, ask them what it is that they enjoy. Now, the goal is not to have them eat cake and cookies and ice cream all day, every day. But there are sometimes your patients may say, having ice cream right now will feel really good on my throat, it's something I want to try. Everything in moderation is okay because they're getting calories in. But in general, we do want to think of a more holistic, healthy diet. But small meals, if your patients have access to nutritional shakes, patients will find they're easy to carry with them. They can sip on them throughout the day so it doesn't feel overwhelming and they don't feel full, if you will. And some patients like to put them in refrigerators. And I've even heard some patients that can take them and mix them with ice and make more of a shake. So that could be an option. With any of us, it's good. We want to relax and chew our food well, right? Because if we chew our food well, that does decrease some of the acidity in our stomach and bile production. And it also will help decrease stomach tension. So we want to encourage some of our patients, ask them to keep a food diary. They can give it to you. And if you have a dietitian that they can partner with, be sure to give that to the dietitian because collectively we can look and determine are there particular foods, right, that's causing them more stomach upset, nausea, or vomiting. And when we think a little more holistic, one of our colleagues here mentioned using mint, the smell of mint, even chewing mint, and ginger. Ginger, most people have access with ginger throughout the world. And so whether they take it whole, ginger tea is a really great recommendation, as well as ginger ale. And so this is when spending time with your patient and giving them alternatives. And when they come back in, follow up with them and find out what's working. We talked on a previous slide, but greasy or spicy foods and foods with strong smells. We hear often from our patients that a smell that to us, it may not bother us, really will cause a reaction to their nausea and vomiting. That's also why clinicians, we want to be thoughtful about what we're wearing. In some areas, we have people that don't wear perfume or cologne, or at least strong perfume or cologne. So just think about that. Cold and bland foods may be more appealing because they also have less odors. And then tart foods, interestingly enough, pickles, lemons, things of that nature help reduce nausea. And once again, we're getting out our toolbox. Find out what works for our patients and what they have access to. So in this instance, carbonated beverages, interesting, could help in moderation with nausea and vomiting. Popsicles, like we talked about, teas, ice chips. And then again, if smells are triggering, look to drink fluids, think soups and other things from a cup with a lid, because that will slow down the odors, and use a straw. All righty, and then some pharmacologic interventions. So we want to encourage our patients. Sometimes we give our patients a prescription that they should be taking it around the clock or at set times. And other times we tell them to take medications as needed. But we want to encourage our patients, in particular, saying they have nausea and vomiting, to take the medication at least 15 minutes before their radiation appointments. Your clinician may prescribe Zofran. There's a medication called Compazine you may have access to. And then there is a combination of a medication, Ativan, Benadryl, and Haldol. So you have to be partnering with your physician or advanced practice provider in your area to understand what you have access to, and then get feedback from your patients. And it isn't just because, let's say, Zofran works for me, it doesn't always work for everybody, right? So you want to, if your patient comes to you saying, I've been taking the Zofran, it's not helping, if they don't have other medications, please reach out to your physician or your advanced practice provider and ask them to prescribe something else. And then encourage, when you're educating your patients, to be proactive. If they know there's certain times where their nausea and vomiting does not seem to be under control, it's okay to do preventative, right? Tell them it's all right to take this more on a regiment versus just once they get nauseous. That is something I think our patients don't always think about, right? Usually we're told only take it when you need it. But in particular, when our patients are undergoing radiation and chemotherapy, it is fine for them to be proactive on certain medications. Okay, so we've got a question. Okay, how often should the patient taking anti-nausea medication or how often should the patient take anti-nausea medication after getting weekly cisplatin? Again, that's our chemotherapy. So only when they feel nauseated, within 8 hours from receiving anti-nausea medication during chemotherapy, then at least every 8 hours for at least 48 hours, once a day, or never, because they are addicting. All right, so we've got some.
I did make these questions a little bit easy, so next time we'll have to make them hard.
Good. We see a couple A's, we see majority of B's. So yes. So remember that when they're taking their chemotherapy, and at least every 8 hours for 48 hours or longer, it just depends. The goal there is to start the regimen and remind them it's okay to continue to take it. For patients with their first round of chemotherapy, as we probably have learned, they're not quite sure what to expect, and we aren't either. But then historically, we can look back and ask them specific questions, and then we can partner with them to say, remember last time, Mrs. Smith, you said on day 3 you started getting really nauseous. So go ahead. It's okay to take your Zofran. And you said it normally lasted for about 2 or 3 days. It's okay to take your Zofran as prescribed. Okay. Great job, everyone. Thank you for your participation in that. All righty. So now we're going to move over to pelvic pain. So some interventions to consider with pelvic pain is there can be over-the-counter medications and including pain medications. Now with pain medications, one of the things that we do want to monitor, some pain medications can affect the motility of the GI tract. Some, right, can cause constipation. Usually we're managing diarrhea, but as nurses, we want to make sure we recognize they can have diarrhea and they can have constipation, and not just pain medications. Now we're going to make a general statement about any medication our patients have. As nurses, we want to make sure we understand the side effects and we can explain those to the patients. And in particular, when they come in, if they're having particular side effects, we want to consider their medications as well. But we have so many non-pharmacological pain reduction methods. So think about meditation, aromatherapy, lavender, mint, spearmint, citrus flavors often help people. Light exercise as tolerated, yoga, right? Stretching, Tai Chi, things of that nature. Massage therapy and acupuncture. Now, when we say massage therapy and acupuncture, we want to be thoughtful about that. If a patient has skin irritation, or they have a lot of tenderness to the lower pelvic area, massage might not be best for them. But even light massage, acupuncture can work really well for a lot of symptoms. But remember, we need to understand where our patients are in their chemotherapy treatment, because if their platelets are low, you probably aren't going to be introducing acupuncture, right? And if you have a clinic where you have a practitioner that does this, they'll also be aware. But we want to caution our patients if they have it available out in their community. So always an opportunity to treat our patients and assess. Okay.
Actually, I'm sorry, did
Yes,
you answer the question about the triple therapy anti-nausea medication regimen?
I didn't see it, but please, what was the question again?
What are your
The
recommendations on triple therapy anti-nausea medication regimen? What does that mean? I guess that's the question. So,
I just moved the slide. Were you talking about the ABH, Ativan, Benadryl, and Haldol? Maybe it was our colleague,
guys,
is that what they were
yeah,
talking
so the
about?
other, just to let you guys, I don't know, actually, did you say I just started with Zofran? But what my answer is, in between, if you're still nauseated, you can take Compazine. But if they're still nauseated, I will add a low dose steroids. So this is where I do add low dose steroids.
Thank you for that, Dr. Jhingran. Yes, and we also, the team member just mentioned this. So unlike with diarrhea, this is where you can add low dose steroids. So the Ativan, Benadryl, and Haldol, it isn't your first line of defense, right? As Dr. Jhingran and I pointed out earlier, we normally start with Zofran. You can alternate with Compazine, but there are some patients that if they have extreme uncontrolled nausea and vomiting, it's a combination medication that we give, and it's usually compounded at our pharmacy. So you would have to go back to your clinic and see what you have access to. Throughout this presentation, I do want to point out that no different than y'all may have access to treatment regimens or medications and other things I might not have access to, or vice versa. So you want to think about locally what you and your clinicians have access to and made those recommendations. Thank you for that question, though. Okay, so moving on to rectal pain. So usually symptoms we find that get irritation and burning. They can have rectal bleeding, and then they have loose stools and diarrhea. So similar with diarrhea, we want to think about the food and their intake, right? So we want them to avoid spicy, greasy, and then very high fiber foods. So with diarrhea, excuse me, and very high fiber foods. Can somebody put in the chat why, again, we want them to avoid very high fiber foods with rectal pain? We touched on it earlier, but it's just a really good point to drive home.
And while people are putting answers in the chat, going back to the nausea, vomiting, and your point, Ashley, in terms of what medications people use, I think is such a great one because it's really depends on what's on formulary, and there's a lot of different medications. And as you said, different patients respond pretty differently to each of the nausea medications over time, and just have to see what works for them.
Absolutely. Thank you for that wonderful summary. So, what you have available where you practice, and then consider might they need different types of medications as well till they find out what works for them. So, yeah, high fiber reduces absorption, making diarrhea worse. Yes, thank you for that. Very high fiber diet. We want to avoid that because it also promotes motility. And when patients already have rectal bleeding and rectal pain, we don't want them to have high motility on that. We've mentioned the use of steroids, right? There's oral steroids, but then we also, when we think about rectal pain, right, we want to consider for our patients, you can, depending upon where you're at, they may have over the counter something called Preparation H, which helps to prevent or limit irritation and burning. It's also used for steroids, but it can be used for that. Hydrocortisone and other topical medications. Patients often they may find that they find a comfort in what's called a sitz bath. Some warm water. You can, depending upon where you live, the patients may have actually access to that already compounded in a package, but they can, and I'll be talking about this on another slide, but they can have a little warm water. They can put some baking soda in there. We want to watch for severe symptoms. We want to educate our patients that if they have watery or bloody stools or fever, that could be something completely different, right? And we want to know about that as soon as possible. And if for some reason, like a lot of our education we do, if the patients won't have access to you because it might be the evening time or a weekend, again, I'm not sure what your clinics look like where you're at, but we want to encourage them when they need to go seek a higher level of acute care, such as an emergency room. But we want to think about infection here, right? And fever, as we know, unless somebody earlier mentioned was talking about the cells dying or tumor lysis, a different conversation, right? And a different topic, but that can cause fever. But in this instance, we're thinking infection. So as nurses, we can recommend to our care team, let's collect some stool samples, right? Because we want to rule out infections such as C. diff. And then depending upon what comes back in the stool sample, they may get antibiotics. And then the antibiotics that you use will of course be dependent upon your area. There is another little education slide I'm going to go over to talk about, but partner with your physician and they will talk to you about a good antibiotic regimen. Alrighty, so moving along, skin irritation. So we've got burning sensations. This is now we're moving on to the treatment side, right? So they may describe a sensation of burning. You visualize redness or blisters on the skin, peeling, right? Chafing, and then skin irritation. In cervical cancer, it depends clearly where we're there is those skin irritation. Now in other areas like breast, depending on we're treating it is more common, but I just want to clarify it does occur, right? I'm sure all of y'all can experience that. Let's talk about some interventions. Patients may find comfort, right? They can take a washcloth, they can put it in a bowl of warm, clean water and with a tablespoon of baking soda. So they can add that. Is available in your area. You may consider, there's a product called Aquaphor. It's something topical that can help with skin healing and to reduce to reduce irritation. But again, it needs to be what you have access to in your area. So in the chat, please go ahead as while I'm talking about this, put what you recommend to your patients. You may have a bandage that is noted to help with any type of skin irritation. Where I work, we have a few choices, but Mepilex is a bandage that we may use. Again, the few of the things that I'm mentioning here is the name of the medication or topical ointment that are applied, but you'll need to use what you have on your formulary or what your patients have access to. So yes, we
And
had,
Ashley,
yes, thank
a
you.
related question from the chat asks, for rectal discomfort, can lidocaine gel applicator be useful for situations of rectal discomfort?
Lidocaine is topical and it can help. That isn't what we would first choose, but it can help with our patients. You just want to be thoughtful though with the amount that you use of lidocaine. It does have a really good numbing effect, but we don't want to have overuse of lidocaine and it needs to be applied properly. But things such as Preparation H and other medications, they have some similar components that help with that. Thank you.
Awesome. And a couple answers in the chat saying looks like Silvadene is a popular choice.
Yes, Silvadene, Curate Silver. Those are all the same, right? It's compounded the same, but those are just what I like to call the fancy pants names of these. So in Cool Magic, again, it's just the name of a product, but they all do the same thing. They help reduce irritation and indirectly reduce pain. Okay, skin irritation, just continuing on that. Let's think about prevention. And again, the focus is what is available in your practice area. So we want to make sure the skin is clean and dry. That's so important. Can anyone throw in the chat why we want the skin to be clean and dry from your perspective?
While people are perhaps putting things into the chat, wanted to bring up maybe a kind of a practical question. Sadru
Yes.
asks, how can flatulence and gas be reduced during external beam radiation? I think related to some of these GI side effects that we've been talking about.
Thank you. That's a really, oh, go ahead.
Go ahead, Ashley. I'm gonna let you answer.
Thank you. I'm sure I'll say some things and I know you'll bring some other really important things. There's a few things when we talk about what patients are eating and drinking. We want to make sure we don't have foods that are naturally produce gas, not too high fiber. We want to help with movement. When we move, that helps with the motility. As I mentioned earlier, when we avoid carbonated drinks, chew your food slowly, because when we chew our food fast, not only do we take in a lot of air, but it also helps with decreasing the acidity. And then a couple other things are coming to mind. There are over-the-counter medications. I'm not sure what's available in your area, but things that actually reduce gas. So that's something as well we can consider for our patients. Dr. Jhingran, anything else that you'd like to add to that?
So did you ask simethicone and gas X?
I did. I just said that. Yes, thank you. So simethicone is something else, but Gas-X, as I mentioned, whatever you have available to your area, most of these things our patients can get over the counter. So we use, like many of the things we're talking about here, we can use a combination of medication and then what our patients also are doing as it relates to their diet, their fluid intake, movement, right? Things of that nature. Thank you. That's an excellent question. So we want the skin to be clean and dry, right? Because we want to prevent infection, and then there's desquamation, right? We don't want the skin to be too moist because then we can have skin breakdown and we can also experience other types of infections. So we also want to minimize the skin contact. We want to encourage our patients to wear loose clothing, so like loose underwear, loose pants, dresses, things that won't rub too often against the skin and cause extra irritation or breakdown. Now, no toilet paper. So let me just clarify that. We clearly want our patients to have good hygiene, but in the event that they are having extra rectal pain or in that area, extra sensitivity, if they have available, think about hypoallergenic or fragrance-free wipes, things that might feel more comfortable to them. Peri bottle, that is just the concept of that is people can put in just some clean water right in a bottle or even a handheld shower. Sometimes our patients feel more comfortable when just using clean liquid to clean off versus when we wipe, as we know there's friction with that. Otherwise, gentle soap and water, and we want to pat dry. When I say no toilet paper, we understand that toilet paper is a common hygiene practice, but there may be times where our patients find more relief with doing these types of interventions. Okay, we want to focus, we don't want to use any scented creams or lotions, but they can consider types of over-the-counter medications that could help. Now, the reason why no scented creams or lotions, because that can be irritating. Any type of synthetic or artificial additive to any type of topical products that we use that normally when our skin is not compromised, it works, right? And people often like the smell with it. But in this instance, we don't want ideally, we don't want them to use any type of lotions or creams that are scented. And then skin barriers. So again, what is available to you, either in your local pharmacies, your local grocery stores, or what they can get through your clinics. So Aquaphor is a brand name, Eucerin's a brand name. I think I saw somebody put in there Vaseline is a brand name. They're all good protective skin barriers, right? Because they can keep moisture in, which is really important. And then with anything, as we talked earlier about, please ensure the skin is dry before covering with a cream because we want to prevent any desquamation to the area. All right, spending more time on skincare is available to the practice in your area. Patients receiving weekly treatment for vulvar cancer should have their skin examined weekly or when there's a change to symptoms. So when your patients come in for your weekly visit, even if they come a few weeks later for whatever reason, this is where we want to ask the questions. As nursing, that's the foundation of what we do. We want to assess. So we're going to ask them, are you having any problems with your skin? Are you having any pain, any redness, any irritation? Then we may need to visually assess, right? And depending upon what we see, that's going to help us determine how we want to treat them. There is something, it's basically a sitz bath, right? We talked about that earlier, and that just happens to be a brand name. but it is helpful for any kind of skin erythema, redness, irritation, or dryness. And there is education, and I'm happy to send this to y'all, but you also can find this on, if you search on any reputable sites, you can get information on sitz bath. And these are things, as I mentioned earlier, our patients can get this at the grocery store, right? So baking soda, that's less expensive and it works, right? They could put a teaspoon of baking soda in some warm water and just use that as well. So they don't necessarily have to go buy something that can be more expensive. I'm not sure if everybody, oh, yes.
The audience. One from
Yes.
earlier asked how does the patient develop incontinence with holding urine after some external beam sessions after they were being treated with full bladder, and related to how can a person who ends up requiring Pampers, diapers for urinary incontinence maintain dry skin? What are some good strategies around those issues?
So thank you. That's a really good question. So if we think about what we're doing in our treatment, that in itself will cause irritation in that area, right? And as you mentioned, it could be loss of bladder control. So what we want to do to support, first, we want to be aware of that. We want to monitor to make sure that they're not having any other side symptoms, as we mentioned, such as blood in the urine, pain with urination, because that could also mean an potential infection, a urinary tract infection, or cystitis is what I think we're talking about as well. When it comes to patients that need to use diapers or pull-up pants or other things because of incontinence, we just need to make sure they're changing that frequently. We want to change that product frequently. We want to make sure that they are cleaning that area. If for some reason they have trouble with their activities of daily living, right, they need assistance on toileting and showering, whoever's taking care of them, we want to encourage them to make sure the adult diaper or brief is clean, similar to with children, right? We don't want to have our children stay in a dirty, wet diaper because that can cause skin irritation and skin breakdown. That's a really excellent question. Thank you for that.
Awesome. Thanks, Ashley.
Okay, now we're going to talk about dressings that relates to skin irritation. We have the disclaimer again, of course, what is available in your area. So maybe while we're talking, y'all can put in the chat what you use where you work. But hydrogel dressings, concept of hydrogel dressings can be applied to areas of moist desquamation when the skin is clean and dry. Diluted Hibiclens. Hibiclens is a brand name, but you can dilute that. You can put it in a little bit of clean water, and they can soak that 1 to 3 times weekly for moist desquamation, or we call it a super infection. We want, if our patients are having really bad skin breakdown or irritation, we may recommend they come in more than once a week, right? So they may come to visit with you twice a week because we want to monitor and make sure there's not additional skin breakdown. And you'll be able to use whichever products you have at your availability. We list here things called Mepilex, Cool Magic. We talked about in another slide, and Hibiclens. But go ahead and use what you have available to your practice, right? That's the beauty of all of this, is that it's the basic concept of how we want to prevent and educate, but use what your patients have available to them. And then for open wounds, again, Hibiclens is a type of cleanser, but use what you have available. Non-adherent wound dressing, right? So I want to just spend a moment. Why do we want to use any type of wound dressing that doesn't adhere to the skin when you have an open wound? Can we have a couple people put into the chat why we want to make sure we use a dressing that doesn't stick to the skin with an open wound? So while y'all are thinking about that, if you already have an open wound, imagine when you get a scratch or a really deep cut. If you put any type of dressing or cover on there that sticks too much, when you pull it off, you risk increasing the size of the wound. You risk infection, right? Because there's adhesive to that. And just additional skin irritation. Yes, exactly. It peels off. It can peel the skin off with removal. So that's why you want to use gauze or what you have available, dressings that the manufacturer says are good for open wounds, right? They're made specifically so they don't deepen the wound, create more concerns to the area, or peel off their skin. What we have listed here our products, but certainly appreciate these might not be available everywhere, and that's okay. So just go back to your area of practice and talk to your pharmacist, talk to your other nursing peers, your nurse educators, and your providers to talk about what do we have and what do we want to use in these situations. And then, as always, we drive it back home. We want to make sure we're constantly educating our patients. Now we're going to talk a little bit more about any type of pharmacological treatments. Again, where the skin reaction is going to depend on how we treat that, but erythema, redness, inflammation within the treatment field should be considered at high risk of including an infectious component, right? So if it's like Dr. Jhingran talked about earlier, we're treating an area of focus, and that's why we bring our patients in regularly. We want to visualize what is going on. So as nurses, there's a great opportunity for us to prevent these things from happening or prevent them from being worsened. So we've talked about it's important to prevent diarrhea, right? Because that increases the risk of skin infection. Topical creams or powders such as nystatin can be applied. Again, always the skin should be clean and dry. And then yeast or fungal infections. If we do any type of not over the counter, prescribed medications, in particular, we put here fluconazole. We always want to check liver functions tests prior to treatment, as well as weekly, depending upon the dosing of fluconazole. So for initial signs and symptoms, the dosing recommendation is 150 milligrams once. But for complicated or more severe, your patient could be prescribed fluconazole. Another name for that is diflucan, 150 milligrams every 72 hours for 2 to 3 doses. And if it's progressive, your provider may prescribe 100 milligrams daily for 7 days. What you'd like to go ahead and just consider that if your patient, like any medication that they're on, make sure you're aware of the medication, look at any side effects and educate your patients on that. And in this instance, unlike anti-nausea medications or other medications where we can say you can take also as needed, you can alternate dosings, of course, with an antibiotic. That is not our practice. Alrighty, so focusing a little bit more on bacterial infections, there's a few different treatment coverage here. Again, your providers will help with this, but I just wanted to educate us as nurses that on that second point, there's going to be different types of coverage for these types of infections. So for staph, we might have sulfamethoxazole or trimethoprim or clindamycin, and we can consider swabbing the area, right? So with a lot of infections, you may be swabbing the skin. You could possibly swab the rectal area. Sometimes we do nasal swabs. It just depends on what's happening. Swabbing the area of treatment, right? And more of the pelvic area. So we'll swab. We can send this off to the lab. And then depending upon what grows out, your provider or pharmacist will prescribe things. Again, suspected herpetic or herpes infection, right? If a blister is present, we want to obtain viral cultures, right? Because herpes, as we know, is a virus. So if the result is positive or for high clinical suspicion, we want to treat with valcyclovir, 500 milligrams twice a day for 3 days. So the goal here for us as nurses is to understand our interventions, right? Sometimes we need to get a swab, a culture to be sent off. So then our pharmacists or providers can make the determination if the patient needs any type of antibiotics. And then as nurses, of course, we always want to treat. We want to teach our patients and symptom management and medication management. Okay, now we're moving along. We're moving along to later long-term side effects. And I'm going to go ahead and pick up. They always say when you're having a good time, it flies. So I'm being respectful of everyone's time here, but this is where we'll find later long-term side effects, and this could occur at greater than or equal or 3 months of treatment. So we talked about urinary problems, premature menopause. This could be any women that are treated with radiation therapy, weakened bones, vaginal stenosis. Very good. Okay, y'all are talking about this topic shortly. So I'm going to just high level this, but vaginal stenosis and why that occurs, and it can cause pain with intercourse, and then hematuria. Excuse me, I'm sorry. I probably need to get some water, but I don't have any water by me, so I'm going to keep moving on. Since y'all are talking about this and reflective of the time, I'm going to move along. So additional long-term side effects, there could be bowel damage, bladder damage. We talked about changes to the skin or coloration. bone damage leading to fracture, depending upon the areas of radiation, and then ovarian damage, right? So causing infertility, sterility, or premature menopause. And if this is a topic y'all don't have in this program, I am sure there are many clinicians that would love to come back and just talk about this in general, right? And we're happy to come back. I'm happy to come back, and or with Dr. Jhingran. And then vaginal damage, which leads to dryness, shrinkage, pain, bleeding, or sexual dysfunction, and then swelling of the genitalia or legs. And I'm going to just move along a little bit. So one of the things that we were asked was talk to us about health promotion strategies, in particular with our patients being treated for gynecologic cancers. A few things that our patients can do, and there's lots of great information out here on this. And if you'd like me to forward it, I'm more than happy to do so through this program. But think about pelvic floor exercises, right? So as women, as we know, when we relax and we control the pelvis, this aids our muscles, right? And so it aids in the treatment and prevention of pain with intercourse and or pelvic exams. It's helping us to have a strong pelvic area, okay? It also helps us draw blood flow to the area. And as we know, blood helps to heal, right? And so enhanced circulation, it also can help with arousal, because that is when we think as men and women both, arousal does occur because of that. And then dilator, we've got a slide about that, but dilator therapy. So when we encourage our patients to do dilator therapy, this allows women to gain confidence and decreased anxiety with intercourse or pelvic exams, because understandably they can have a sense, they can feel scared or overwhelmed because they're anticipating pain or discomfort. It also aids in the treatment of stenosis and adhesions, and it increases flexibility of the tissue. So I think, my understanding, you're going to have some talks about this, but just a little bit about dilator. Again, the purpose is to prevent scar tissue in the vagina or shortening or narrowing of the vagina. So we want our patients to consider using dilators within the first week after treatment. And they can use it 2 to 3 times a week for 10 to 15 minutes is tolerated. I think there was a question in there. Yes, water soluble lubricants will be very important, right? Because not only does it prevent friction with use of the dilator, but it also will help to reduce the pain, and proper insertion of the dilation for most benefit. And then sexual intercourse should be considered 7 to 10 days after the last radiation treatment. So this slide just shows a few different dilators. And some of these you may find familiar with where you're at, but our patients do have options. So what is available to you in your practice? We want to encourage you to use vaginal lubricants. It's a liquid or gel to reduce pain with sexual activity due to dryness. I think I've seen in the chat a few of these names, but whatever you have available, KY jelly, Astroglide, yes, those are a few. And then vaginal moisturizers. So that's actually applied to the vagina. Usually there's ways to insert it to assist in hydrating the vagina. And this is related also to hormonal depletion. And we talked a little bit about perimenopause, which women receiving that have gynecological cancers and we're treating with radiation, they experience that. So it can be applied internal and external, and there's just some examples. Okay, and I know we are at time for sure, so I am gonna just go through these slides, but I want to encourage everyone to please reach out directly. Hormonal replacement therapy, whether oral or a topical cream or in combination, this is so important for our patients to improve vaginal and sexual health after radiation therapy. And then hormonal replacement is also important for bone health and memory up to the age of at least 50 years. Over here is a study, but what this did is it showed actually, with hormonal replacement therapy or HRT, it showed the outcomes of patients related to vaginal dryness, shortening, vaginal tightening, pain during intercourse, and sexual enjoyment, those that were on hormonal therapy versus not on hormonal therapy. And there was a little over 1,000 patients in this study, and they did this study for a period of 50 months. So we saw, and the p-value for most of them really showed their alternative hypothesis, which was, does hormonal therapy help prevent these symptoms or lessen these symptoms? It does work. Okay.
And Ashley, a
Yes.
quick question from the chat asks, why is sexual intercourse discouraged during treatment itself?
Oh,
That's a really great question.
I'm going to answer that. It's not
Yes.
discouraged. What I tell my patients is that it can cause pain, that can cause can cause you to have mental issues. It gives you mental feedback on scaring you to have sex afterwards, right? It can cause bleeding, it can cause discharge, but it's not harmful to the significant other, but it's more harmful to the patient just because of the symptoms that can happen. But it isn't like the big thing is if it causes more bleeding. That would be the only big negative thing to it. Does that
Thank
make
you.
sense?
Thank you for that question, and thank you for that answer, Dr. Jhingran. And as was highlighted in the previous slides, the reason why we do encourage the vaginal dilators and the vaginal moisturizers and the gels is because of that and the lubricants. Because as Dr. Jhingran pointed out, you can have pain and irritation, and we don't want our patients to get anxious, right, around having intercourse, because it's something very natural and our patients enjoy that. And so it's a way for us to help them have comfort and ensure that they can have a healthy sexual lifestyle if that is their choice. Just a little more information here about primary and secondary prevention. Primary prevention, like we mentioned, our providers, our radiation oncologists, they can look at their treatment plans associated with this. But then our secondary prevention is nurses, right? We want to focus on education around dilators, lubricants. We want to counsel before, during, and after treatment. When they follow up, we want to ask them these questions, right? As nurses, we have a wonderful opportunity to connect with our patients and they feel comfortable with us. And this is a very personal topic, right? And so you have these relationships with your patients. So we want to talk to them about that. There are sexual screening questionnaires we can do and checklists that you may have this in your practice. And then we can also refer our patients for further counseling, right? And if some of our patients, if they have a gynecologist, of course, they can also partner with their gynecologist as it relates to more long-term care in these areas. All righty, so we're getting close to wrapping up. We want to just do another assessment questions. When should you start the dilator after treatment? 1 to 2 weeks after treatment, 1 month after treatment, 3 months after treatment, or when scarring is noted on the exam? All right, I'm seeing a lot of, okay, as they say, we're all getting A pluses in here. Yes. So the answer, like we talked about in a previous slide, is 1 to 2 weeks after treatment. So that will help prevent any scarring to the area, any shrinkage, if you will, scarring to the area. And then will also, because keeping that area open will then help in a positive way so the patients won't have pain during intercourse in general. Okay, so I'm going to wrap up here with us. We're going to summarize. So we've talked about what is radiation therapy, in general. We've talked about overviews of gynecological cancer, treatment modalities, and then we spent a lot of times on symptom management and symptoms. But now I'm going to wrap it up for us to think about as nurses in our workflow. So when our patients come to us for that initial visit, a consult that we can call it, our new patient visit, and you can see in each column, you'll either find that our patients have intact gynecological cancers receiving definitive radiation. Then in the middle is post-operative gynecological cancers. And then at the end is metastatic disease, retreating treatment to other parts of the body. So for us as nurses, when they come in that first time, we want to focus on a list of questions, right? We want to ask them, have they had surgery? That's important, right? We're going to confirm often 6 to 7 weeks of chemoradiation is recommended, followed by brachytherapy or a boost. And this is what Dr. Jhingran talked about. When they come in for post-operative gyn cancers, so if you have a patient that's seeing you for the first time that has post-operations, then we're going to focus on questions to include about how are they doing with their surgery. They may have had vaginal cuff treatments or pelvic radiation with or without chemotherapy. And then on here, you want to check either the patient's outside records or your own internal documents, right? Look at the medical note and find out what their treatment plan is. Patients usually know this information. You're gathering not only this for yourself, but now we're thinking about handing off to the provider, whether it's an advanced practice provider or your physician. And then if they have metastatic disease and they're receiving treatment to other areas of the body, we want to focus on their overall wellness. What bothers you the most? What treatments have you received to date? Like, how can we help you in particular? Sometimes when patients have metastatic disease, it is a lot about symptom management. And this is where radiation can play a role, right, to help reduce some symptoms. As you plan for your appointment, we want you to consider, again, to summarize, ask your patient when was the last date of any chemo, radiation, or surgery. What does the referral say about why they are being sent to your clinic? Any outside records, any providers that may work in your organization. We want to focus on pre-radiation questions, such as making sure they don't have prior radiation, a defibrillator, or things that we need to know about if they're being treated by radiation therapy. We want to focus on their social needs. This is so important. As nurses, that's the foundation of what we do, right? We learned this the first month of nursing school, holistic patient care. So do you want to consult to your patient, to a physical therapist, an occupational therapist, dietitian, social work, case management? We have so many partners. Dr. Jhingran highlighted the importance of when they come in and we see them on a regular basis, right? And we've talked about symptom management when they come and things to look for. So again, for patients that are in the first category, we want to talk about what has changed since we saw you recently. We want to ask what's occurring in the vaginal area, the vulva area, and ask about the skin. Are you having pain, irritation? Is there redness to the site? Are you having vaginal bleeding? And then for post-operative cancer patients, we want to, again, focus on the same things. And then for patients with metastatic disease, there may, again, if there's metastatic disease, we may be treating other parts of the body, right? And so we want to consider that. What happens when we're treating other parts of the body? So questions for you to focus on as nurses. Again, as the patient receiving chemotherapy, how many fractions of radiation? We've talked about brachytherapy. So is brachytherapy with anesthesia planned? If you have that treatment available where you're at, then this is a good time to start education. You'll be partnering with your providers on this. And then again, if there's brachytherapy, is it going to be without a cuff or a planned per prescription? We want to understand that, right? And so this is something we're going to be talking to our providers with that. Because if so, then it's depending upon in your area, but as nurses, you may partner with the sizing, the simulation of the patient, and treatment appointments, right? We usually find this in our post-operative patients, but this just highlights what we do as nurses as it relates to care coordination. And this is what you'll, again, want to focus on in this last slide when you're handing this off to your providers. So same types of questions, right? Looks like that's the same slide. There we go. All right. The last thing I want to focus on, weekly Cs. We call them weekly Cs, but whatever you call them, where you're at, where you see your patients on a regular basis during treatment. Summarizing what we've talked about: diarrhea, nausea, vomiting, pain, fatigue, constipation, urinary toxicity, vaginal hemorrhage, and vaginal discharge. There are other things, as we know, our oncology patients can be experiencing. So that's what you may focus on, but ask them some open-ended questions, right? We don't want our patients to get so focused on these things that they may not tell you something else that could be important for us to know to ensure they're getting the ideal patient care and safe outcomes. So with that, we are going to wrap up. I know we were over by a few minutes. I'm so appreciative of everyone's time today.